All right, sorry everybody, it's a bit of a late start. Let's get started though. My name is Benjamin Lamb. I'm one of the cognitive neurologists over at Sunnybrook Hospital. Thanks very much for coming this morning. A real pleasure to meet the group of you. Slightly larger crowd than last year. What we're going to do, I think, this morning mostly is just to go over some of the issues around cognitive neurology. And I think you guys have the slide set already, so we'll just get started. The first talk of this block is going to be about memory specifically. And just plowing right into it, no disclosures. This goes over some of the major learning objectives introduced at the beginning of the week to go over two of the major assessments that we use in the clinic, particularly in primary care. This includes the Mini Mental Status Examination, or the MMSE, and the Montreal Cognitive Assessment, or the MOCA. And then to go over really the diagnostic sort of considerations for the two main entities that we're likely to encounter in the clinical setting, that being mild cognitive impairment as well as dementia. And then we're going to talk a little bit about the classic pathology of Alzheimer's disease. We're going to cap off, and we're going to revisit this again actually in the third lecture as well, just some little things about the treatment of Alzheimer's and dementia more generally, limited those, though those options might be. Okay, so what is memory? Memory is probably one of the most defining elements of being human. There are certainly other higher chordates who are capable of memory function. We know this because we use mice, for instance, with the Morris Water maze to do a lot of our studies in memory and dementia. The important thing about memory is that it allows an organism to exist in time. Without memory, there is no future, there's no past, you're always just simply in the present. And we'll see that in the illustrative case in just a little bit. The important things about memory is it allows us to learn. That's the practical thing. I mean, that's what all of you guys are doing right now. It's the acquisition of new language. From a biologic, physiologic perspective, what that is encoding. So your neurons basically form new dendritic connections. For those of you with a more sort of basic physiology background, and it's those dendritic connections, current thinking anyways, that allows us to form new memories. So a lot of this was, for better or worse, depending on one's perspective, discovered by folks investigating this unfortunate young gentleman. So HM was an individual who had intractable seizures, and back in the day there really wasn't very much that we could do for folks like him. The honest truth is there's still a lot of folks like him for whom we can't do very much aside for cutting out the part of the brain that's generating the seizures. Those of you who will rotate through sick kids will certainly see that. But what happened in his case was they took out both of his hippocampi. And this, of course, was before we knew what the hippocampus did. It was, a part of the temporal lobe. They weren't sure. They thought maybe it was important, but they had to do it. So they took both of his mesial temporal areas out. And you can see sort of down here, this is the region, and they just took it right out. So what happened? I think you guys have little response thingies. Is that the case? I'm not sure. Yes. Okay. Okay. I only got 3 responses. This is why the younger generation needs to vote more. Oh, okay. Yeah. Being told I should wait. I will wait. By the way, while we're waiting for responses, you guys are welcome to interrupt at any time. The lateness aside, we should have enough time to clarify things that come up in the lecture as they go, okay? I'm going to talk kind of quickly, but feel free to interrupt. Okay, all right, so got 26 responses. How do I actually see the responses? Click on the show. Oh, okay. Dope. Oh. All right. Episodic memory. Great. and some of you thought all of the above. So the main answer is episodic memory. You are going to have some disruption of some of these other elements as well. Semantic memory, if you guys recall, in contradistinction to episodic memory, is facts. So, for instance, that Eurasia is the largest continent, or that Canada is the largest coastline in the world, that sort of thing. The episodic memory is where there's irrelevant context, right? So how this relates to an individual is someone who has an episodic memory deficit will, for instance, remember perhaps that they're married. They may even remember where they were married. They may even remember the date they were married. They won't remember whether they liked the cake. They won't remember how they felt. They won't remember their motivations or any of the actual nuance and context to that experience. So that's what episodic memory is. Non-declarative memory or procedural memory is more sort of learned behavior and learned information that your body accesses without conscious thought. So riding a bike would be an example. The hippocampus is absolutely critical for episodic memory formation. And so when your hippocampus is missing, particularly when both of them are missing, you have essentially total anterograde amnesia. You cannot exist beyond the present. And so one of the descriptions by Brenda Milner, who was the neuropsychologist who drove a lot of the investigations in the HM, said that every day was sort of alone in itself. And the hippocampus and the extrahippocampal structures are critical, absolutely critical for memory. That's what we learned from HM. Now, what was very interesting was that despite having both of his memory centers removed, he was still actually able to encode some information. So what Milner did was she had him copy a figure, and the way she did it was there was actually a star that was sort of an outline, and he had to stay within two very narrow parallel lines of that outline and not touch either side. And he did this actually while looking at a mirror. So as you might imagine, a very complex visual spatial task. And what would happen is that as he came back day after day to do this procedure, it took increasingly fewer trials for him to actually encode that task until he was able to do it without touching the lines. And so Milner was able to demonstrate with this that HM was still able to acquire new skills despite having complete anterograde episodic amnesia. And this is where one of the first instances of procedural memory became apparent to us. So I should not have revealed that. Okay, so we'll just go ahead with that. That was an example of procedural memory. Sorry about that, guys. Sort of jumped the gun there. And non-declarative memory is really just another way of saying procedural memory in many cases. So the conceptual framework for diagnosis, this is something that's very important, and it's evolving. A lot of the information that I'm going to be sharing with you guys now seems very commonplace and simple, but a lot of it actually didn't exist as recently as 10, 15 years ago, which I know for a lot of you seems like a long time. The diagnostic criteria for Alzheimer's disease, as you now understand it, remember, is at this point almost 30 years old, 30, 35 years old. So these entities are actually fairly recent. What we usually start with is the clinical phenotype. And from the clinical phenotype, we try to create neuroanatomical underpinnings. So again, this whole sort of where is the lesion, what is the lesion, the whole idea of localization. And we'll revisit that again in both this lecture as well as later in lecture 3. And then what is the underlying pathophysiologic process or pathological diagnosis that is driving these anatomical changes? So if we illustrate this discussion with a case very quickly, this is a 66-year-old woman who is an architect, and she presents essentially with subjective concerns of forgetting. And these have been progressive and gradual over the last year. There's no interference with her day-to-day activities. Mood and affect are unaffected. Sleep is unaffected. And her past medical history includes some vascular risk factors, remote smoking, hypertension, and hypercholesterolemia. And her medications reflect those vascular risk factors. She's on an angiotensin converting enzyme inhibitor as well as a statin. So her examination is normal, and these are her MoCA and MMSE. We'll go over what those mean in greater detail later, although I think you guys already know that from the reading in the case. So the MMSE is 28, and what's very notable is that the difficulties she had there specifically were on the delayed verbal recall. She could only remember 2 of the 3 words after a short delay. On the MoCA, remember that there are 5 words on the target and she was not able to remember 3 of them. What was interesting is that she was able to salvage 1 of the words with cueing. And then she has some issues with orientation, and then some issues with serial subtraction. This is her investigations, essentially normal. And the neuroimaging is supposed to illustrate just 2 things very specifically. This is normal, just for your comparison, and this is her. So there are 2 things that I want to draw your attention to. The first is that her hippocampus, remember this is the area that HM had lost through the surgery, her hippocampus is slightly shrunken. And you know that because you'll notice there's this sliver of dark gray. That's the CSF density of the temporal horns of her lateral ventricle. Those are not really visible or at all very apparent on the normal individual. So because you have this ex vacuo dilatation of the lateral horns, you can tell that this individual, our architect, has a little bit of hippocampal atrophy. More obviously, you can tell that her third ventricles are quite enlarged as compared to the normal individual. So differential diagnosis for memory loss includes things like neurodegeneration, and so we're talking about things like mild cognitive impairment secondary to things like Alzheimer's disease, Alzheimer's dementia, toxic metabolic, TSH, B12 being key considerations, thyroid abnormalities. Sleep disruption, obstructive sleep apnea can certainly contribute to the presentation of dementia or to memory loss. Psychiatric issues, including depression. Medication effects, very important, particularly in the geriatric population. The whole issue of polypharmacy. A lot of individuals in this age group will either be on or have recently been exposed to anticholinergic medications. And so those are things to consider. Post-concussive, TBI, the whole NFL story with chronic traumatic encephalopathy as an illustrative example of this. Infectious and autoimmune as well as paraneoplastic syndromes. Consider these whenever the onset is fairly acute and the progression fairly rapid, especially if the person is otherwise young. These are big red flags for possible infectious or paraneoplastic causes. And then vascular and demyelinating white matter changes in particular. So normal aging does damage the memory centers over time. What you can get is, especially if you have, for instance, hypertension, other cerebrovascular risk factors, certain genetic predispositions like apolipoprotein epsilon 4, and certain nutritional exposure issues can either increase or decrease the likelihood that your memory will decline. The French, not surprisingly, have done a lot of studies on this, including the Tri-City study that showed that certain things like coffee, espresso in their case, was helpful for memory. So you have to have at least 3 a day, is my understanding. Not that you guys should necessarily binge on coffee, but and then the MIND diet, which is the Mediterranean diet that people talk about. Memory changes that occur with normal aging. Procedural memory tends to be intact. You know how to ride a bike when you're 4 or 5 years old. You're going to know how to ride a bike when you're 80 or 90 years old. Semantic memory is generally intact, but as one gets older, you can get this tip of the tongue syndrome. So your staff, when it's 3 in the morning and you're reviewing with them over the phone, please be kind and talk slowly because we might still be waking up and having trouble with our semantic recall. So we'll know what the diagnosis is. We might just be very slow in telling you. And that happens when you're young. So remember that our cognitive peak is in our 20s and 30s, and after that it goes downhill. So things to look forward to when you guys are junior attendings. Episodic memory can decline with normal aging. And remember again that there is a precipitous drop-off at around 60. It's one of the reasons why people come to their family docs or to the memory clinic in their 50s and 60s, and they're really worried because maybe they have a family history of Alzheimer's or something similar, and they're wondering whether or not their episodic memory problems are related to this. So the criteria for MCI, this is the National Institutes on Aging Alzheimer's Association criteria. And what's ironic is that if you talk to most people in the field, this is the quote-unquote new criteria, and it's like at this point 7 years old. You have to have objective as well as subjective concern that there is memory loss. Objective impairment has to be verified. This is where the MMSE and MOCA comes into play. We'll go over that in just a wee bit. Independence, if you recall, is the major demarcation between mild cognitive impairment and dementia. Function is preserved. This definition is also the same for those of you who are destined for psychiatry in the DSM-5. The DSM-5 makes a similar distinction. And the ICD-10, for those of you who are interested in public policy and health, United Nations coding is exactly the same. This may change by the time you guys are in practice. There is active debate as to whether or not function should play a role in the diagnostic classifications of these conditions. But for now, for the purpose of your exam, it does. You're not demented. Honestly, if you have the first three, you pretty much have to be not demented. No other reversible or identifiable causes. Now, it's very important to note that in the definitions, they talk about the predominant cause. So if, for instance, depression or TBI or the fact that the person is only sleeping 3 hours because they're waking up 6 times to go to the bathroom from benign prostatic hypertrophy, just because those things are causing memory problems, if that's not the main reason that you think they're having memory problems, you cannot rule out the possibility that they may actually have Alzheimer's disease, right? It used to be, back in 1984, when the first version of this criteria came out, that Alzheimer's and neurodegenerative dementia was a diagnosis of essentially exclusion. That is no longer the case. You can have Alzheimer's disease and depression at the same time. And we'll go into that a little bit as well a little bit later. So MCI, single domain versus multi-domain, this is something they talk about as well. These are the 5 main cognitive domains. I don't put social cognition, which is identified in the DSM-5, only because that's not usually the parlance that we use in neurology, but those are all relevant. And you can have either amnestic, when memory is the primary domain that's affected, versus non-amnestic, when it's one of the other 4. And the issue with making that distinction is that amnestic MCI in the epidemiologic studies generally correlates with the greatest risk of conversion to eventually having Alzheimer's dementia. If you have non-amnestic MCI, you tend to convert into something else, or you tend to be stable. So this whole issue of MCI having a 10 to 12% annual risk of converting to dementia is really relevant for people for whom you have other things in their history that makes you worried they actually have Alzheimer's disease. The whole issue of depression, OSA, hypertension, and this being more vascular, those are the people who tend not to convert, or the worried wells, right? The 60-year-old executive who is no longer able to remember lists in their head and have to rely on their iPhone or whatever to remember their client lists. If they don't convert, it's because they actually just have normal cognitive aging per 3 slides ago. So the MCI workup, which is incidentally, spoiler alert, the same as the Alzheimer's disease workup or Alzheimer's dementia workup. This is the American Academy Neurology recommendations, B12 TSH CBC, again, just to rule out common reversible causes. It is the one patient out of 600 that you forget to order these that will invariably have a decrease in their B12. Not that that has ever happened to anyone I know or myself. The electrolytes, extended lights, very important to look at. LFTs are important to look at because they can sometimes keep company with unusual autoimmune presentations. And it's also just a nice screen if you have any concerns or suspect that there may be alcohol use or overuse issues. Neuroimaging. So this is very contentious. The different specialties are radically different in terms of their approaches to this. And with fair reason on both sides. Some of the specialties very much advocate that no matter who you see, as long as they have objective and subjective concerns with their cognition, that they merit some kind of neuroimaging, even if you're fairly certain that they don't have a tumor, they don't have, a stroke or any of these other quote-unquote reversible causes or secondary causes of dementia. Some other specialties will feel that this is over-investigation and you're going to find all sorts of random things, plus it's an incredible use of healthcare resources. This is something that you guys are going to have to learn as you guys go through the ranks in residency. They tell you that medical school teaches you what you know, but it's residency that teaches you what you believe. So I'm going to leave that for you guys to discover in the next 5 years or so. Additional considerations. Specialist referral. Again, if you are concerned that this individual has a more complex presentation, or if you think this individual may benefit from high-level care as a way of possibly even disease modifying their course, then that's a very appropriate time to refer them to a specialist clinic. Honestly, in Toronto, we're very fortunate that we have quite a few specialist clinics, so it may not be unreasonable just simply to refer everybody that you have concerns for. SPECT or PET scan. SPECT is more in Ontario, PET is more in Quebec, and SPECT again more in the rest of Canada, PET more in the States, SPECT more in Europe. It's very, as you can see, willy-nilly as to what the actual modality is a good functional proxy test. And CSF analysis is, just so you know, not really available generally. The only time we ever do it is when we suspect early onset Alzheimer's disease because of the potential implications for employment and because genetic risks are usually more present in the young onset cases that we actually send them for this testing, because it's about $100, $150, and it has to go, $1,000, $1,200, and has to go to the States in order to do this. And patients may have to pay out of pocket. So this is a very restricted test. Incidentally, in Scandinavia, they do this for everybody. Sleep study, if you have any concerns about obstructive sleep apnea, and then psychiatric referral again. Now, psychiatric referral could be for two reasons. It could be because you're concerned this person may have a primary psychiatric disorder. It could also be because, as part of their neurodegenerative dementia, they have prominent behavioral and psychiatric symptoms. And it's very appropriate in that circumstance to ask your psychiatric colleagues for help, because all of the medications we use may affect their cognition, sometimes in a beneficial way. So, going over the two assessments. The mini mental status examination is probably older than everyone in this room by a fair amount. It's over 40 years old. I hope I'm not aging anybody. But the thing to keep in mind was that the very idea of Alzheimer's disease didn't really exist. So if I could just segue for 2 seconds, at this time period, they thought that Alzheimer's disease, due to amyloid and tau pathology, was this weird esoteric genetic disorder that only affected young people, and that dementia, as you and I would recognize it and use the term for, was predominantly caused by quote-unquote hardening of the arteries. The idea of atherosclerosis and that terminology was still actually in the process of being codified. And so the mini mental status exam was really an attempt to identify people who were quote-unquote getting sort of normal quote-unquote aging because of hardening of the arteries, lots of air quotes here, versus having this weird esoteric genetic thing. And as you might imagine, a lot of the tests were very much dependent on memory, because that was the main thing people were worried about. And it was also very, very heavily language laden. So orientation. Orientation is not a cognitive domain. Okay? Orientation actually is long-term memory. That is what allows you to orient. Your long-term memory is what tells you it's 2018, not 1970. Or I guess more relevant to you guys, 1995 or something like that. Okay? People with long-term memory deficits start losing track of what era of life they are in. Registration is immediate recall or short-term registration. And then after a short delay, the MMSE asks people for delayed verbal recall, which is uncued. The very idea of retrieval versus encoding deficits was still kind of very new at the time, wasn't really widely looked at, and there was no reason to, right? Because the only thing that existed at the time was quote-unquote dementia and quote-unquote this unusual Alzheimer's disease thing. The idea of vascular dementia, the idea of diffuse Lewy body disease, the idea of frontal temporal dementia, they weren't going to be invented for another 20 to 30 years. Okay, so that's why the MMSE suffers for being relatively insensate to these things. Mild cognitive impairment would not become a diagnostic entity until about 30 years after the MMSE was created. The MMSE was really meant to determine whether someone had dementia. So the Montreal Cognitive Assessment comes along after all of these other diagnostic entities exist, and it is far superior in many ways. So one of the things that, just focusing on memory for now, it does is that it looks at other things too. So for instance, semantic recall, this is part of your sort of long-term fund of knowledge, which plays into naming. And just anecdotally, everyone gets the rhinoceros wrong. It's a hippopotamus for some reason. Incidentally, if people say it's a unicorn and they come from the Middle East, it's actually okay, because that's a direct translation of the word in those languages. Yeah. And I learned that early in fellowship. And remember, this is a test of their semantic knowledge, not of their English. Okay. The other thing is that the words are a lot more complex, right? Not everyone uses words like velvet and daisy on a regular basis. So those are lower frequency words. It tests your memory just a little bit more. And the important thing is that not only is there an encoding task, but in the delay task, there is a cued component. Now, we don't actually score the cueing, but this is where it's important to treat the MMSE and the MoCA. I tell this to all the residents who rotate through the Cogneuro rotation at Sunnybrook. Don't treat these tests as lists to go through. Treat them as physical exam maneuvers. And just like you guys are learning in ASCM how not to just simply go through a series of motions in your physical exam, don't go through the motions of filling out checkboxes and putting down numbers when you're doing either the mental status exam when you guys are doing your psych rotations, or, for instance, cognitive testing when you're going through the neurology rotations, right? Think of this, you guys are doctors, so think of this as a person who's using this test to figure out what's going on with your patient. And then orientation, which we talked about already, is a long-term memory function. So that was pretty much it in terms of just the actual MMSE and the MoCA. Now the MMSE, again, is not as sensitive. That's also evident in the Linda Lee article you guys all read, and that is very much true because it was never designed to look for the thing that didn't exist when it was created. It doesn't really have as much words. We talked about this a little bit. The delay period is not long enough. Now, what's not talked about here, and I'm just going to segue again for 2 minutes, is that the MoCA is also superior because it deals with executive function, visual, spatial, and attention, which are all things that we became as a field much more aware of as these other diagnostic entities came into existence. So those are other reasons to consider using the Montreal Cognitive Assessment. Incidentally, it is perfectly acceptable to start doing one, abort, and move to the other. You guys are also more than welcome to do the different items out of order. If you think an item is not relevant to your patient, you can skip it. Again, you guys are doctors, so just tear it apart, use it however you want to use it. Neuropsychological testing, I'm just going to really quickly talk about that it's only useful if there are really high-level reasons for being concerned about this individual. So let's say they're a 55-year-old president of a startup that is now 15 years into its existence, so not a startup anymore, and he or she manages over 100 employees, and they're beginning to have issues remembering just little things, right? That's someone that you may want to just double check and make sure that they are still fit, for instance, for their position, and that they're not looking at the likelihood of early onset dementia, in the near future. So when there are employment concerns, for instance, we look for neuropsychological testing. When there are questions about the diagnosis, does this person, for instance, have adult attention deficit disorder, which is underdiagnosed and very common, especially amongst professionals, just FYI, then it's important to see whether or not the cognitive pattern is one that's more consistent with inattention versus memory. So those are the reasons why we generally do it. And sometimes we do it because we want to establish a baseline for an individual who has a high risk. They have, let's say, 2 parents who both had late onset Alzheimer's disease, and 3 out of their 7 siblings, all 3 of them older than them by a few years, have memory decline and or actual diagnosed dementia. These are people who are very high risk. This is someone that you may want to do this testing on, even if they just have very, very mild symptoms. So that's what we use neuropsych testing for. It tends not to be available. MCI treatment. Bottom line is that the non-pharmacological management options is really where we're at. Okay? The triad that I always discuss in the clinic is engagement socially and mentally, engagement in terms of physical activity, and diet. Those are probably the biggest things that a patient can take ownership of and take control of. Now, that's very important to discuss with your patients in the clinic because they're basically contending with an illness that is removing their agency. So by talking about these things, you're kind of giving them back a little bit of agency, and they do respond to it, especially when they're in the MCI range. Because remember, these are people who are still, generally speaking, functioning quite well. You want to treat, obviously, depression if it's present. You want to treat and identify sleep issues if they're present. And you want to avoid any sort of exacerbants, either prescribed or otherwise, that might be impairing their mental status. And in terms of pharmacological treatment, the teaching is that the cholinesterase inhibitors are not helpful at this stage of disease, and that is true. So if you look at all of the randomized control trials, there's no evidence that on the primary endpoints, which were cognitive and also conversion to dementia, there was any change between the treatment and placebo arms. However, big however, keep in mind that some of these people may be young and they still might actually be in work. So even though it is the case that you're not necessarily going to keep them from developing Alzheimer's disease, you might actually allow them to function well enough that they stay in their job. and that's not something that is going to be captured in an RCT. They actually gave air traffic controllers galantamine and found that their response times and judgment and accuracy was superior to those who were not on galantamine. Not that you guys should try to get a black market supply and take it just before your exams, but yes, the cholinesterase inhibitors do actually improve your focus and attention for a short period of time. The main reason is that it will give you guys nausea and gastrointestinal upset. I'll tell you that right now, because your cholinesterase systems are fine. Alzheimer's disease, most common subtype, greater than 50% of all dementias. It's the whole issue of the aging population. There are over 500,000 Canadians who have dementia already, and by the time another generation rolls around, that number is going to triple. And as you guys can see from the prevalence data, I mean, ignore the numbers for a moment. The most important thing I want you guys to take away from this are two things. The first is that age is the single most important driver of dementia risk, full stop. Okay, it's not genetics, it's not diet, it's not whether or not, you smoked or, drank too much. It's not whether or not you had your 3 coffees or exercise or all the rest of that. All of those things do contribute, but the most important thing that drives this is age. The other thing I want you guys to take away is a rule that's sort of embedded in there, which is that the prevalence at age 65 is 0.5% and the risk doubles every 5 years. If you can remember that rule, you guys will be able to answer any of the questions on the exam with regards to epidemiology of dementia risk. For reasons that are still not fully understood, women do seem to be at greater risk, and this is even after controlling for the fact that certainly for our parents' generation and for our grandparents' generation, women tended to outlive men. And there are any number of theories as to why that might be. That is beyond the scope of this particular class. So just mindful of time, with regards to the NIAA criteria for Alzheimer's disease, as you guys can see, it looks very similar to the criteria for MCI. The big thing to keep in mind here is that you need to actually make a very clear judgment about the domain. So is this person with Alzheimer's disease amnestic or memory predominant, or are they non-amnestic, so visual, spatial, executive, language, or attention? And that's pretty much it. The only difference between the two criteria really is that to meet the definitional threshold of dementia, you need to have functional deterioration. And again, that is an area of active debate. It may be that in 5-10 years, that will change. Alzheimer's disease, clinical presentation. We talked about this a little bit. Consider which domains are affected. So that feeds into the issue of localization. We'll go into localization by domain in the third lecture. But the reason that's important is that if you can localize where you think the disease is occurring, that actually gives you a very good idea as to what the underlying pathology likely is. So it will help you diagnostically. Now, the question that I often get asked is, why does it matter? Right? We don't have any real treatments for any of these diseases. The treatments for all of these diseases, modest as they are all essentially the same. The reason is because the prognosis is quite different. The prognosis for someone with DLB, for instance, is radically different than the prognosis for someone with semantic dementia. The other thing is that even if we can't do anything about them right now, we may be able to do something about them in the future. And it's very different when, say, you have someone who you think may have Alzheimer's disease versus someone who you're almost certain has Alzheimer's disease, into whether or not you want to, say, put them on some sort of disease-modifying thing if and when it becomes available. The other thing is that it's important for their children. A lot of these diseases have variable degrees of genetic inheritance. And so if you're able to identify somebody as having Alzheimer's as opposed to, say, DLB, that means a lot, actually, to their kids. So something to keep in mind. One of the important presentations with Alzheimer's dementia is that there can be early apathy and irritability. The irritability is essentially a little bit of depression peeking through. And later on, as that depression and the behavioral psychiatric symptoms continue to progress, you can get issues with agitation. Wandering occurs due to visual spatial impairments. You can get hallucinations, not just in DLB, but also in Alzheimer's disease for that reason. And you can get misidentification syndromes for a similar reason. In Alzheimer's disease, we often talk about a combination of things, wayfinding and word-finding difficulties. So we all know about the memory loss in Alzheimer's disease. That's when the hippocampus, the mesial temporal areas are damaged. As that damage progresses to the posterior cortical association areas, that's when you can get your wayfinding and word-finding difficulties. Now, it's not in the slides, and I don't think it's going to be in any of your exam questions. But it will not be in any of your exam questions. Dementias, just so you know, tend to affect one side of the brain first. And for reasons that are not fully understood, it tends to affect the left brain. Actually, it's a very interesting story. So for those of you who are interested, you can read up on the evolutionary vulnerability of the human brain, that by developing the ability to have memory and to have sentience, we also simultaneously develop the ability to have dementia, because dementia does not affect a lot of other chordates. But anyways, when the disease affects your parietal lobe, if it affects the parietal lobe on your left more, parietal temporal lobe, that's when you get your word finding difficulties. If it affects your parietal temporal lobe on the right side more, that's when you get your visual spatial and your wayfinding difficulties. Apraxia is, of course, a parietal function, and so not surprisingly, that is also a major and prominent component of these diseases. Sleep disturbances can often occur because of disruptions in your circadian rhythm. Circadian rhythm disruptions may be both a cause and effect of neurodegeneration, again, beyond the scope of this lecture. Seizures are usually a late finding in people with typical neurodegenerative dementia, neurodegenerative Alzheimer's disease. That is not the case for people with early onset disease. So we usually traditionally think of late onset individuals, people who get this disease in their mid-70s, mid-80s. Those are the people who have 10 years. They're gonna die in 10 years. And they're gonna die with their Alzheimer's disease, not of their Alzheimer's disease. They're gonna fall and break their hip. They're gonna get a pneumonia. They're gonna get a PE, something like that. Okay. If you develop early onset Alzheimer's disease, particularly if you have an autosomal dominant form of it, this is those presenilin 1 and 2 mutation stuff, the onset is usually in the 40s, 50s, or the early 60s. Usually people are dead within 5 years, and they die of their Alzheimer's disease, not with their Alzheimer's disease. There is so much cortical damage from that form of Alzheimer's that people actually develop seizures. They go into status epilepticus. They're on 4 or 5 agents. You can't bring them out of their seizures, and they die. So just keep that in mind, that seizures actually could potentially be quite significant and severe in the young onset cases. Motor signs, just be vigilant for those because they can occur just with aging. Parkinson's disease, again, one of the most important drivers of that illness is just age. And also a lot of the conditions that can cause dementia in terms of cognitive decline can also lead to Parkinsonism, not necessarily Parkinson's disease. And then primitive reflexes, it's kind of an interesting story. I just had a conversation with a neuropsychologist who literally wrote the book on the frontal lobes, and don't quote me on this, but he said that the primitive reflex exam is not very useful. But still do it anyways on your OSCEs. So non-amnestic presentations, more common in young people, and these are the main ones: visual spatial or the posterior cortical atrophy variant, language variant or logopenic progressive aphasia, and then this behavioral frontal executive syndrome, which can mimic FTD. Mixed dementia is actually extremely common. In fact, honestly, most people have mixed dementia. They don't have pure Alzheimer's or anything else. Risk factors, again, the most important risk factor is age. Everything else is sort of secondary. Women, for reasons we don't understand, again, are more likely to get it. We talked a little bit about ApoE4 and how that can increase your risk. Do not go and start offering testing. It is not considered appropriate or standard of care. And the reason is that although it very significantly increases the risk, just because you're an ApoE4 carrier, even if you're a double carrier, doesn't mean that you're going to develop Alzheimer's disease. So you're not actually giving them additional information, you're just making them worried. And there's actually a body of literature to suggest that people may actually go on and commit suicide after learning this information and then Googling what it means. I'm not kidding about that. So do not offer this. And when we do ApoE4 testing in the context of research, we actually seal that data so that we don't even know it to accidentally give it to the patient, just FYI. Depression, vascular risk factors, all things that can lead to, so again, these are not just mimics, these are actually risk factors for dementia. Severe head injury, of course, can do it. Sedentary lifestyle, that feeds into that whole issue of metabolic syndrome, vascular risk factors, and medication exposures. Workup, we already talked about this. It's exactly the same as MCI. I'm not going to belabor the point, but it is exactly the same. Structural imaging. So we already talked about our architect and how you have to look at the hippocampus. That's probably one of the most important indicators that this person may have a neurodegenerative pathology. And of course, also the fact that the ventricles will have ex-vacuole dilatation. On the axial cuts, this is what it looks like. The temporal horns just expand significantly. AD pathology, gross pathology is atrophy again in these areas, temporal and parietal areas, as well as in the hippocampal region. Biochemically, there's a cholinergic deficit due to atrophy in the basal forebrain, which creates acetylcholine. And the hallmark are extracellular amyloid plaques, focus on the extracellular for esoteric exam purposes due to amyloid beta, and the intracellular tau neurofibrillary tangles that are flame-shaped. That's pretty much it. Next time you will see these slides after medical school will be on the Royal College if you decide to go into neurology, or I guess if you go into pathology as well. Okay, cerebral amyloid angiopathy, it's a very rare condition. The amyloid deposits not around your nerves, but around your blood vessels, and it weakens the walls and it leads to both lobar hemorrhages as well as microhemorrhages. So it's hard to see here, but there are these little black spots on the susceptibility weighted imaging, and those are essentially heme deposits. Okay, genetics, early onset, more likely to be related to autosomal dominant disease. I already talked about presenilin 1 and 2, developed by one of our colleagues actually just down the street, and amyloid precursor protein, which is the pre-protein for amyloid beta. So if you have mutations in one of these genes, essentially what it does is it affects the processing of amyloid precursor protein, and so you get more amyloid in your brain, and it's not rocket science. You may have an atypical presentation, and again, it's more common to have an atypical presentation in people who are younger. And this is in contradistinction to people who have late onset, for which ApoE4 is more of a driver, and there actually is more familial clustering. So even though we talk about autosomal dominant inheritance as being more important early onset, just general genetic factors are more important in late onset disease. So the usual figure is that if you have one first-degree relative, so a parent, a sibling, or a child who has Alzheimer's, your risk is doubled. So remember that rule, 0.5% at age 65. Doubling doesn't really make much of a difference. Okay, so that 60-year-old who is worried because they have a parent who has Alzheimer's disease, they probably don't have to worry too much when they're 60, because their risk at that point is probably approaching 0.2, 0.1%. When they are 75, however, their risk is going to be approaching 5%. And so that is much more significant. And then by the time they're 85 or 90, their risk is going to be into the teens to low 20s. So there, having a family member with Alzheimer's disease is a pretty big deal. Down syndrome, again, not surprisingly, because APP is on chromosome 21. So just by having the additional dose of amyloid precursor protein, these folks develop more amyloid. It's one of the reasons, actually, they get cataracts early on. Cataracts are due to amyloid deposition in your eyes. Management for actual dementia this time. So we do talk about pharmacological agents for this. Again, I think the nuance is beyond the scope of you guys, but just so you guys know, there is a lot of debate amongst the different specialties. Some very much favor the use of cholinesterase inhibitors, such as neurology. Some of them do not feel that it is appropriate. So again, this is one of the things I'll leave for you guys to determine for yourselves. However, for exam purposes, the three main cholinesterase inhibitors that we talk about are donepezil, rivastigmine, and galantamine. They're all essentially the same, more or less. Galantamine, just FYI, interestingly, even though it was the last to get approved in North America, has actually been in use in Eastern Europe for a very long time for myasthenia gravis, because it's a cholinesterase inhibitor. And what's very interesting is that it's derived from a plant. So if people are very hesitant to go onto a quote-unquote chemical for their memory, I sometimes talk about the fact that galantamine is a phytoderivative. It has been processed and all the rest, it makes it a little bit more palatable. The main side effects are GI upset, which can occur in up to 10 to 20% of people, and the reason is that it will accelerate your gut through effects on the parasympathetics. It is for the same reason that people have issues with presyncope, syncope, and heart block, because it increases the tone of the vagus nerve to the sinoatrial node, and it, as a result, may reduce someone's basal heart rate. It's not exactly a beta blocker, so it's not quite that severe, but it can have that effect. NMDA antagonists, There's only one really, memantine. And what it does is it reduces the likelihood of excitotoxicity, glutaminergic excitotoxicity. And the hope there is that you're able to retain function and a little bit of cognition. The truth is that by the time you start memantine, which is usually into the moderate stage of dementia, preserving cognition is not the primary concern. The primary concern is maintaining function. And so that is actually something that memantine has been shown to do over and over again in RCTs. Side effects include dizziness, confusions. It's actually a very mild drug. I talk about these with my patients. The honest truth is that it almost never happens. The main thing you need to be careful about is that it is associated with seizures. So if you have someone who has had seizures, or you start the medication and they develop a seizure, you may need to stop it. Non-pharmacological management is exactly the same as it was for MCI, right? The whole exercise, social and mental engagement, diet, and of course trying to remove or reduce exacerbants that may be causing issues, alcohol reduction. One of the reasons we recommend people slow down or to stop alcohol intake is not necessarily even because of the direct effects of alcohol, which is a depressant on the central nervous system. It is because they will forget that they had drunken, or they had had their drink. And so moderate drinkers, as they begin to develop their amnestic disorder, one of the signs actually is that there are partially finished shots of vodka or glasses of wine all around the house. And basically they turn into people who overuse alcohol through no intent. It's just they have forgotten that they drank. And as they lose the insight that they have an amnestic disorder, they get upset that people are getting on their case for drinking when they weren't drinking, in air quotes. Vascular risk factor control. Safety issues are very important. So driving, very thorny subject, won't go into that too much. Falls have to be assessed, especially if you're worried about Parkinsonism, and similarly swallowing as well, although that's usually a late factor. And then fostering supports. And don't forget that this is a disease of more than one person. Kind of like with pediatrics, you're not treating an individual, you're treating an individual and the people around them. So caregivers have to be assessed pretty much every time you see someone in the clinic as well. Behavioral symptoms, non-pharmacological options are, of course, usually best. I won't go into them too much. Music, though, I will highlight. Music is because, sound processing and also smell processing are very old functions of the brain. We share that with a lot of our rodent cousins and lizard cousins for that matter. So it is a part of the brain that remains relatively preserved and accessible even when higher order cognition is lost. And you may have heard about the Memory and Aging program in Toronto, where the Alzheimer's Association will give iPods to seniors loaded with music that they would have liked in their 20s and 30s. And that actually helps to preserve their cognition. Cholinesterase inhibitors and memantine we talked about, they are not just for cognition. They actually do reduce the behavioral psychiatric symptoms. And this is where you may want to refer to your psychiatric colleagues if you're not as familiar with SSRIs, SNRIs, and neuroleptics. Okay, last question, I think. Main difference feature between mild cognitive impairment and dementia is? Okay, we got 19 responses. I think that's enough. And you guys are correct. That's pretty much it. Okay, so this is going to be, those are just the last things with regards to the sort of non-Alzheimer's disease causes of dementia. And I'm just going to go over these really quickly. So transient global amnesia, it's very profound. I hope you guys do get to see a case. One, because it's actually quite benign for the patient. Two, because you will never forget it. And it will actually improve, I think, your acumen as physicians. But you get this very profound anterograde amnesia. It's basically like they've turned into HM for a day. And it's very common. But the thing is, it completely reverses. And there is no permanent loss in difficulties. So you know what, I think I'm going to actually stop there, only because I think Dr. Friedman is going to be starting very soon. And then I'm going to pick back up here, just finish these two slides, and we're going to segue to the last talk, if that's okay with you guys. All right? Thanks very much.